We are going to discuss benign epithelial lesions of breast. These lesions are divided into three groups according to the subsequent risk of developing breast cancer. Number 1, non-proliferative breast changes. Number 2, proliferative breast disease. Number 3, atypical hyperplasia. Non-proliferative breast changes. This group includes a number of very common morphological alterations that are often grouped under the term fibrocystic changes. It is for the clinicians. The term might mean lumpy, bumpy breast on palpation. Fibrocystic changes, it is the most common condition which involves the female breast. It mainly affects the women who is in the 3rd to 5th decade of life. It can be bilateral and multifocal. The breast tissue is irregular, firm, and nodular with discrete lumps. The clue to diagnosis is the disappearance of mass after fine needle aspiration of cyst. No risk of developing cancer. Hormonal balance is blamed to be an etiological factor, that is increased estrogen and decreased progesterone. The breast nodularity typically fluctuates with every menstrual cycle. Morphology. There are three main morphological changes. Number 1, cystic change, often with apocrine metaplasia. Number 2, fibrosis. And number 3, adenosis. Gross appearances. The breast tissue is irregular, rubbery, and fibrotic. Macroscopically, the cyst containing clear or turbid fluid. Blue dome cysts may be present. Cyst formation. Small cysts are formed by the dilatation and unfolding of lobules, which in turn may coalesce to form large cysts. Large cysts contain turbid, semi-transparent fluid which produce a brown to blue color to these cysts, resulting in the formation of a blue dome cyst. These cysts are lined by either a cuboidal flattened atrophic epithelium or by apocrine metaplastic cells. The metaplastic cells have an abundant granular eosinophilic cytoplasm and round nuclei, closely resemble the normal apocrine epithelium of sweat glands. Calcification are common and may be detected by mammographic examination. Milk of calcium is a term used by mammographers to describe the calcifications that line the bottom of a rounded cyst. Cysts are worrisome, which are either solitary and firm to palpation. This photograph shows macroscopic appearances of fibrocystic change. The cysts are shown here. The larger cyst is marked, whereas smaller cysts are shown by letter C, and there is stromal fibrosis in the surrounding areas. This photograph shows the gross appearance of blue dome cyst. This is the microscopic appearance of fibrocystic change, in which the formation of variable cysts are shown and labeled. This is the photograph showing apocrine metaplasia, which is marked with red arrow. In smaller cysts, the lining epithelium showing metaplasia is marked with MPC. Metaplastic apocrine cells have eosinophilic, abundant granular cytoplasm with small, rounded, hyperchromatic nuclei. Fibrosis. These cysts frequently rupture to release of secretory material into the adjacent stroma. There is resulting in chronic inflammation, which leads to dense periductal and perilobular fibrosis. The fibrosis contribute to the palpable firmness of the breast. Now this photograph shows cyst formation and stromal fibrosis, which are labeled. Adenosis, it is defined as an increase in the number of acini per lobule. The ducts have an oval or elongated contour well-defined epithelial and myoepithelial layers. A physiological adenosis is seen during pregnancy and lactation. Otherwise, adenosis can occur as a focal change. The acini often enlarged, called blunt duct adenosis. Calcifications may be present within the lumens. The acini are lined by columnar cells which may appear benign or show atypical changes. The flat epithelial atypia, a clonal disorder which is associated with deletion of chromosome 16q, which may be the earliest recognizable precursor of low-grade epithelial neoplasm. Now, this is the photograph which shows acini increased in number per lobule, and they are marked with red circle. Proliferative breast diseases without Atypia. These changes or lesions are mostly detected as mammographic densities, calcifications, or as incidental biopsy findings. Each one of them could be found singly, but more than one lesion is present, frequently in association with non-proliferative breast changes. These lesions are characterized by proliferation of ductal epithelium or stroma without cytological atypia, and architectural pattern is maintained. Hyperplasia without atypia. The normal breast ducts and lobules are lined by a double layer of myoepithelial cells and luminal cells. This condition is defined by the presence of more than two cell layers. This consists of both luminal and myoepithelial cell types which fill and distend ducts and lobules, or defined as it is architecturally, cytologically, molecularly heterogeneous benign proliferation which primarily involves the terminal duct lobular units. This hyperplasia may be mild to florid. The cuboidal cells lining the ducts, ductules, and lobules showing small glandular pattern called fenestrations. It is usually an incidental finding on biopsy. Other terminologies used for these conditions are intraductal hyperplasia, hyperplasia of the usual type, or unusual ductal hyperplasia. This photograph shows that there is a solid proliferation of cells filling the space. The cells and nuclei vary in size, shape, and orientation. In this photograph, there is solid proliferation of the cells but forming the lumina at the periphery. Sclerosing adenosis, there is an increase in the number of acini per terminal duct to at least double the number found in uninvolved lobules. Multiple well-defined foci are usually present. The normal lobular arrangement is maintained. The involved acini are compressed and distorted in the central portion of the lesion but dilated at the periphery. Myoepithelial cells are usually prominent. Sometimes stromal fibrosis is so marked that it may completely compress the lumens to create the presence of solid cords or double strands of cells lying within the dense stroma. The histological pattern at times closely mimics the presence of invasive carcinoma. Sclerosing adenosis present with palpable mass or radiological density or calcifications. Apocrine adenosis, there is ductule proliferation with extensive apocrine metaplasia. These cells have large nucleolus. Now the photograph showing microscopic features of sclerosing adenosis, in which closely packed ducts are present but the lobular configuration is maintained. There is a photograph showing sclerosing adenosis in which dense collagenous stroma marked with letter F surrounding the proliferating lobules. Microcalcifications are present in the lobules which are marked with letter C. Microglandular adenosis, a rare variant. There is a haphazard arrangement of small, round ductules which lack lobular architecture. There is hypocellular and collagenous stroma in the background. The proliferating ducts often extend around normal breast ducts and lobules and may also extend into the adjacent adipose tissue. The duct lumina may contain a colloid-like eosinophilic secretory material which is PAS positive. There are bland cytological features of cells which typically show clear or vacuolated cytoplasm and rare mitotic figures. The atypical microglandular adenosis has foci of both typical adenosis and areas of complex structure and cytological atypia. Myoepithelial layer is absent, negative for S100 protein, smooth muscle actin, smooth muscle myosin heavy chain, and P53, usually negative for EMA and estrogen receptor. The photograph shows microscopic features of microglandular adenosis in which dense collagenous stromal background and the proliferating lobules without architecture. Complex sclerosing lesion and radial scar. It is uncommon before 30 years of age. It is typically small and therefore usually non-palpable. It is an incidental finding which is associated with adenosis and fibrocystic changes. On mammogram, it shows a dense central radiolucent zone with linear densities radiating outward. Microcalcifications may be seen. It mimics like carcinoma on mammography. In many patients, this lesion is multifocal or bilateral and clustering of scars may occur. Gross appearances. The lesion is typically of small size, rarely larger than 1 centimeter. Radial scar refers to lesions greater than 1 centimeter. The term complex sclerosing lesion describes lesions up to 1 centimeter. It shows irregular, stellate, dense fibrotic tissue, may grossly mimic like carcinoma. Microscopic features. They are pseudo-infiltrative lesions. The central collagenous scar showing fibrosis and elastosis which entraps ducts showing dual epithelial and myoepithelial layer. The basement membrane is intact. The epithelial proliferation with stellate or radial arrangement of ductules resembling sclerosing adenosis. The fibrocystic change includes ductal hyperplasia, ductectasia, adenosis, and papillomatosis surrounding the fibrotic zone. The ductal lining may show schemous metaplasia. Perineural infiltration is seen by benign ducts. Small areas of necrosis may be present. These ducts should not infiltrate into the surrounding adipose tissue. Carcinoma has been seen to arise in a background of radial scar. They are believed to be benign but associated with atypia and malignancy. Radial scar may be an independent risk factor for the development of breast carcinoma. Immunohistochemistry, SMA, myothelial layer positive, S100 protein, myothelial layer positive. The photograph shows radial scar showing stellate appearance which is caused by bands of dense fibrous connective tissue extending outward from the central core which is labeled and the radiating bands of fibrous connective tissue marked with red arrow. Now this is the photograph showing microscopic features of radial scar. The radial scar is labeled in the photograph and the red arrow is pointing towards it. At low power, it resembles the head of a flower with a fibroblastic, comparatively acellular center surrounded by dilated glandular structures showing variable degrees of epithelial hyperplasia and ductal dilatation, dark pink stroma representing elastosis. Intraductal papilloma, solitary papilloma, it arises from lactiferous ducts in the central breast tissue beneath the areola. It often presents with serous or bloody nipple discharge. It is found in women between 50 to 60 years of age. Multiple papillomas, they are multiple papillary masses which typically located in peripheral ductal tissue in contiguous branches of the ductal system. It occurs in women around 40 to 50 years of age. They are less frequent than solitary papillomas. Gross appearances, large papillomata may be visible in the lumen of a dilated or cystic duct. The palpable lesions typically measure 3 to 4 centimeter, but the cystic lesions can be larger than 10 centimeter. Microscopic features, there is an organized papillary formation of ductal epithelium on a frond-forming fibrovascular core or stroma. There may be any degree of epithelial hyperplasia of the usual type. The fusion of papillae may result in gland-like spaces or solid areas. There are presence of a layer of myoepithelial cells in papillae and around glandular spaces. However, they can be focally absent. The papillomas may show apocrine, squamous, mucinous, clear cell or sebaceous metaplasia. Their cores may undergo sclerosis and entrapment of ductal epithelium may occur, which may be mistaken for invasive carcinoma. Infarction may be associated with torsion of the cores, hindering the evaluation of atypia and malignancy. Solitary papilloma, papillae with single layer of cuboidal to columnar epithelium and focal epithelial hyperplasia may be seen. This lesion may show minimal cellular atypia and rare mitotic activity. This may show extreme distortion and fusion of papillary fronds called solid intraductal papilloma or marked sclerosis known as sclerosing papilloma. Multiple papillomas show involvement of more than one duct system or multiple foci within a single duct system. They may show prominent epithelial hyperplasia. The atypical changes may develop with papillae lined by pseudostratified or elongated epithelial cells. Papillomas, either solitary or multiple, even without atypia, show an increased risk for malignancy. The risk is greater with multiple lesions. Women with multiple papillomas with atypia have a high risk of developing breast carcinoma. Most important features for differentiating between a benign papilloma and a papillary carcinoma is the presence of a uniform myoepithelial layer in the proliferating papillary intraluminal component. Most important point, the presence of apocrine metaplasia within the lesion favors a benign lesion. Another most important point, immunohistochemistry, SMA, calponin, S100 protein, smooth muscle, myosin heavy chain and P53 are positive for myoepithelial cells. Now the photograph shows microscopic features of intraductal papilloma. A central fibrovascular core is extending from the wall of a duct. The papillae are branching within the lumen and are lined by myoepithelial and luminal cells. Now this photograph shows multiple papillomata which are marked with letter P, whereas fibrovascular core is marked with letter C. Florid papillomatosis of the nipple may be seen at any age of female but more common in middle-aged women. They are very rarely reported in men. They present with serous or bloody nipple discharge. The patient complains of pain or itching sensations. A palpable mass is present in most cases. Gross appearances, it forms a discrete mass. The nipple frequently shows ulceration, erythema and scaling. Microscopic features. The characteristic feature is florid ductal hyperplasia. They are grouped into 4 subtypes according to their growth pattern: sclerosing, papillomatosis, papilloma, adenosis, and mixed proliferative patterns. The myoepithelial cell hyperplasia is common but inconspicuous or absent in sclerosing lesions. Foci of necrosis and normal mitosis may be seen. Areas of atypical ductal hyperplasia, duct carcinoma in situ within papillomatosis may also be seen. Immunohistochemistry, SMA, calponin, S100 protein, smooth muscle myosin heavy chain, and P53 show positivity for myoepithelial cells. Now this photograph shows florid papillomatosis of the nipple of the breast. Florid papillomatosis is marked with letters FP, whereas the skin of the nipple is marked with letter S. Pseudoangiomatous stromal hyperplasia. This lesion is seen in women of childbearing age. It presents as a firm, palpable, non-tender, solitary breast mass or an area of thickening. It can be found as an incidental biopsy finding. Gross appearances, it is well circumscribed and encapsulated lesion. Its size varies between 3 to 4 centimeter. On cut section, it shows a fibrous, tan white, homogeneous tumor. Microscopic features, the lesion is characterized by complex anastomosing empty spaces which appear slit-like, that is pseudoangiomas. In a dense collagenous stroma, these empty spaces are lined by monomorphic myofibroblastic spindle cells which resemble endothelial cells. There may be solid foci of prominent spindle cells. Immunohistochemistry, vimentin positive in spindle cells forming pseudoangiomatous space. CD31 rarely positive, SMA variable positive. Now this is the photograph showing microscopic features of pseudoangiomatous stromal hyperplasia. There are empty spaces which show anastomosis and are present in the dense stroma. Now there are certain benign lesions which mimic carcinoma. Number 1, sclerosing lesions like sclerosing adenosis, radial scar, ductal adenoma may be mistaken for infiltrating carcinoma. The presence of apocrine metaplasia or coexisting DCIS may cause a particular problem. Benign epithelial hyperplasia of duct type can be mistaken for carcinoma in situ. Benign intraductal papilloma. Differentiation between benign and malignant papillary lesions is frequently difficult. Sclerosis with an intraductal papilloma further increase the problem and may mimic infiltrating carcinoma. Similarly, problems can occur with ductal adenomas. Physiological hyperplasias like florid hyperplastic changes seen in secretory breast during pregnancy and lactation can be alarming. Reactive changes, occasionally chronic inflammation around a cyst or in an area of fat necrosis, when viewed at low power, resembles infiltrating carcinoma. Treatment-induced changes, epithelial atypia may be striking. Radiation and chemotherapy can induce changes in the epithelium.